Welcome back, ladies and gentlemen. Hope you enjoyed your morning tea. Our next two speakers are Melanie Hay and Harry Patsamanis. Melanie has extensive and widespread experience across the primary and secondary healthcare sectors in the areas of quality improvement, change management and stakeholder engagement. She holds the role of Strategic Advisor, Heart Health Initiatives to the Victorian Cardiac Clinical Network and is the DHSV Delegate for the Prometheus Project. She is author of the Heart Failure Toolkit and led the Health Innovation and Reform Council project around reducing heart failure readmissions. Harry Patsamanis is the Clinical Strategy Advisor with the National Heart Foundation, where he has a key role in the delivery and evaluation of the warning signs of heart attack strategy, the work to improve models of care and reduce avoidable readmission in heart failure, improving cardiac rehabilitation, and the implementation of integrated health check prevention pathways. Please welcome our dynamic duo, Melanie Hay and Harry Patsamanis.
Thank you, thanks. Thank you very much, Angela, for that introduction, and also I'd just like to thank Dental Health Services Victoria for giving us both this opportunity to present today. So I like the introduction about the dynamic duo because it does feel a little bit like that. This is quite an inclusive project. It's all about partnerships, and the Cardiac Clinical Network under the auspice of Safer Care Victoria, which Diane referred to earlier this morning, are working closely with the Heart Foundation to progress this work. And what we'll be focusing on today is sharing some learnings around how we've started to work with ICHOM and more broadly across the sector in terms of implementing heart failure PROMs. So hopefully you'll be able to glean some information from that as you start your own journey. In reflection, looking and listening to Diane and also Jacob this morning, I get quite excited, to be honest, because really it's an opportunity that we're very happy and proud to be part of in terms of trying to shift how the system delivers care to its patients. And I'll put some data up around variation that we have seen in heart failure and why there was a desire and definitely a need to do something different here. So today I wanted to really focus on a few different things. This has been quite a journey to date. So we're going to talk about the Prometheus Project, but the Prometheus is where we're at the moment. There's a whole history behind this, and I'll just take you through quite quickly what that means in terms of delivering value-based heart failure care. Also what we hope to achieve with the Prometheus Project, and this is where Harry and I'll work as a bit of a tag team, and some of these early insights in terms of taking these principles and actually putting them into practice. So it's all about the implementation, which I think is the really difficult part. So you've got these innovative concepts, you've got things that are causing a lot of discussion, but what does that mean in terms of actually seeing it in practice, getting all your clinicians on board and getting everyone excited about what this could mean? So this was the problem that faced us probably a few years ago now. There was a task force that was set up called the Health Innovation and Reform Council, and they were tasked to look across all the health system, look across all the public and the private hospitals and really do a data mining exercise. And this exercise was to bring forward where within the system we should focus our attention in terms of areas for innovation and reform. And heart failure readmissions in particular came forward as a priority area. So what you'll see from here is that there were two key things that this data brought to the surface. The first one was, I'll just test this out. Maybe the angle's not right. Heart failure readmission rates. So in particular, 30-day heart failure readmission rates. And what we found that across the state of Victoria, there was a 1 in 4 chance that if you were admitted into hospital with heart failure, that you would return to a health service within 30 days of being discharged. So 25.3%, 30-day heart failure readmission rate. And also, as Diane mentioned this morning, variation across health services, how one health service was, say, performing in terms of readmission rates in comparison. Yeah, we don't want a whole screen visual of myself, I don't think. In comparison to other health services. So we saw widespread variation. And this ranged, and I'm not sure if you can see it on that infographic, but we had some hospitals representing data of 13%, so a 13% 30-day heart failure readmission rate. And then at the other end, some hospitals were presenting with data which correlated to a 1 in 3 chance of coming back. So roughly a 33% readmission rate. So I think that's quite a scary thought. And it just sort of highlights the fact that we were seeing quite significant variation across the state. And heart failure readmissions, or readmissions in particular, are both a priority across multiple different areas. So federally, the Health Atlas that again was referred to earlier, readmissions is a priority area there. And also many of you may be familiar with the primary health networks. One of their key strategic priorities is about reducing readmission rates back into hospital. So the department responded and funded an initiative. I think it had something a little more flashy than reducing heart failure readmissions, but that's the best I could remember. And I actually was the project manager at the time for it, so I should really know that in better detail. But the Cardiac Clinical Network funded this initiative, but it was actually led by the Heart Foundation. So that's when this partnership first began. So the goal was really to deliver a value-based, system-wide quality improvement, some sort of a solution, which incorporated 2 key elements. The first one was data, and the second element being the patient. So we sort of went, well, what does this mean? So the data element I already sort of highlighted to some degree in terms of we wanted an evidence base that there was need for change. But equally, we wanted to incorporate within our solution the idea that you can use data to drive your own system and quality improvement. So feed that information back to the clinicians, and then they look, they discuss, and it results in clinical change. And also the patient. I think across all sectors, there's a focus on patient-centred care, wrapping the needs around the patient. But if you look at how these 2 circles come together with that sort of Venn diagram, I think that sort of shaded area in the middle really pulls together where our relationship first started with ICHOM. So the outcome measures or the data to give us an indication of what's actually happening from a patient perspective. So this was quite a collaborative project. We had a lot of hospitals, well, I shouldn't say a lot, it's a bit of an exaggeration, 6, 7 who really informed this solution, but there was a lot of energy and activity across the whole sector. So we put forward a vision. So to deliver a patient-centred, informed, we wanted it to be targeted. It helps in terms of saying we are addressing readmission rates, but we are trying to build this value-based system for heart failure care. And importantly, we wanted it to be measurable. So have a measurable approach to addressing heart failure readmissions within the acute setting. So just to clearly define that we are looking in that sort of hospital where the hospital can have impact, whilst encouraging healthcare providers to connect, to share what they've already found works, and also to champion that innovation. So the process was quite comprehensive. We had this 12-month period where we had input from our heart failure experts. We had an expert advisory group overseeing and guiding this initiative. We also had another project that we funded over at Monash University, which was taking place sort of at the same time, around the journey of the heart failure patient. So we took some of those learnings, incorporated them into this solution, but at the same time, quite fortuitously, I think ICHOM contacted the Heart Foundation and said, look, we're at the stage now where we're actually looking to pull together a heart failure standard outcomes set. And automatically, I think it was just right for us, this is exactly what we were looking for, where those two sort of circles come together. And that's where our relationship with Jacob and the broader team really first started. So we also worked extensively with hospital leaders, appreciating that our focus was the public sector. But if you look back at that infographic and you see the groups who were functioning at that 13% readmission rate, that was from some of our private hospitals. So they were very open. They wanted to share, what has worked for them. So we worked across both public and private hospitals. Equally, we looked at existing resources, wanted to pull out what did we already have in place, what were the real pearls that were out there in the sector. We undertook a comprehensive lit review, and also we started another partnership with Telstra Health. So you may be familiar that they're working in health now, and they have quite strong data analytical capabilities. So for the purposes of this initiative, the department was actually trialling this type of analytical interface or capability that they had developed. And what it was able to do is use VAED, so the Victorian Admitted Episodic Data, the data that comes from hospitals where you determine funding models. They were actually able to use that data and represent it in a way that was quite clinically meaningful back to the clinicians around heart failure readmissions in particular. So again, it was going back to data to drive quality improvement. And also I think the key thing was recognising that, this was a fairly big ask. This was going to be a clinical process redesign concept. So we really needed to build into it, redesign methodologies, what has worked, what does work. When we start to think about implementing this toolkit, well, we actually want to already, even while it's taking shape, we want to think about how we're going to implement it and build those concepts into what this solution, and I've already said the word, the toolkit, so I've given it away, but what it's going to look like. So this is what the end result was. So the heart failure toolkit, it is available online. Have a hard copy if anyone is super keen to have a look at it in any detail today. But you can find it by Googling it. At the moment, there's a little hiccup, I think, with a broken link, but just Google the Heart Failure Toolkit on the Heart Foundation website. So what I'll do quickly is just represent to you what these three sections meant in terms of ultimately delivering optimised heart failure care with a focus on reducing heart failure readmissions. So this morning we've heard from Jacob around describing the value of PROMs, so I won't go into further detail about this, but we also recognise the importance in terms of building that relationship and strengthening that relationship, particularly between the patient and the healthcare provider, but also from a funder's perspective to get a better understanding of how the dollars that were being provided to hospitals were actually improving the care of the patient in terms of what they actually wanted out of their heart failure care. So this is how our standard set shaped up for heart failure. And I put this up because I wanted to just mention that, as I said, Monash University was working on an initiative at the time, the journey of the heart failure patient. And they were also bringing forward sort of these principles around what mattered to a heart failure patient. And as this was taking shape, sort of the two things were like working side by side. And as this circle of the standard set was taking shape, we could actually see quite clearly that what our own heart failure patients were saying was of value to them was being echoed and mirrored in what this international representation was for heart failure. So in terms of giving us a level of confidence and reassurance in using this in our forward thinking, it was a really comfortable place to be. And we also had an opportunity for some of our patients to contribute to validating this standard set. So we had them with iPads, they did a quick survey, and so we had Australian representation in what this looked like. So section 2 of that toolkit, and you'll appreciate this later on when I start to talk about Prometheus and where we're up to with this. But it came down to really a targeted approach to reducing heart failure readmission. So 3 key pillars. So the first one was around heart failure specialty input, or getting that heart failure expertise is really important in this particular area very early on. The second one is around education, and it's not only education for the patient and the carer around their condition, but it's also ensuring that education which is delivered by the healthcare professionals, which at times can be many, many different people having a touch point with this patient, that it's consistent. So we were finding that there were inconsistent messaging coming through. And also, I think the one that keeps surfacing all the time is around transitions. So moving the patient out of the acute setting, how are they going to be best managed in the community to set them up for success? So the third section, as I mentioned earlier, is around implementation. So this can possibly be the biggest barrier. So a solution can fall over before it's really even begun. So we wanted to make sure that there was strong program management, there was strong communication, and also strong change management principles in order for this to be successful when the toolkit's being implemented in the sector. So the end goal from our perspective, it's interesting with Diane's presentation this morning that it really reiterates the use of data, feeding it back to the clinicians. So as part of Safer Care Victoria and VAHI, or the Information Health Agency, we'll be working together around what this looks like. And this particular project, the Prometheus Project, which is the implementation of this toolkit, is going to inform some of those steps that they take, which is quite exciting. So we have broader cardiovascular health strategies to improve services for people with heart disease, strengthen system performance, and also data to drive quality improvement. So reiterating those morning discussions. But also the network has already provided significant investment to what's known as VCOR, or the Victorian Cardiac Outcomes Registry. And this has the capability to capture heart failure clinical information within our health services. So this particular project has funded a small module, an IT module build, which sits along this registry, particularly focused around capturing PROMs, the heart failure PROMs. So we're starting to try and sort of build in that system where we can marry the two sets of data. And ultimately, the pilot, we need to get some solid data around seeing this used within the sector, and then we'll look to embed and scale it across the state and hopefully, more widely. So we have got ICHOM supporting this process also from a PROMs perspective, and they'll look to develop an implementation guide for heart failure, so helping the broader sector to get their head around what this actually means in practice. And I guess this is just a little bit of a representation about what is our end goal, what would we love to see here. So if we're going to put some measures on the table, ultimately it's a triangulation for us between patient outcome measures, our clinical measures, what is best practice for heart failure, and also system measures. So there are certain requirements that when put in practice, it tightens up the system and supports the heart failure patient and the carer. So this is where in a minute I'll hand over to Harry and I introduce you to what is Prometheus. So I think Prometheus from memory is a Greek Titan god known for foresight, which I think is fantastic. A few years from now we might look back and go, how appropriate. But at the moment that's not the case. It was purely because it's a lovely acronym, how it fell out of the project. So we've got our PROM component, so our patient reported outcome measure component. We have one of those pillars, which was education. Another pillar where we transitioned the patient out of the hospital into the community setting, and where we're supporting heart failure, early heart failure expertise or early heart failure input. And ultimately, we're looking to unify systems, so reduce that variation of care across the board and try and get everyone looking at data to drive quality improvement. So collectively, I'd like to introduce you to Prometheus, where Harry will now take over and give you a little bit more detail about taking those principles into practice. Thank you. Thanks.
Thank you, and I think I need to start with a disclosure. My Greek heritage may have had some influence on the naming of the project. I think the other thing about Prometheus is that he actually the gods weren't very happy with him. So his punishment for bringing fire to mankind was that he was tied to a rock and had an eagle eat his liver. So the moral of the story is that innovation can be painful, but it's worth doing. So the project, and there's a number of aspects to the Prometheus project. The one that I'll focus on today is the one in the red circle, which is about our proms. But it is really about optimising care, looking at value-based healthcare, and then disseminating that information, like Prometheus did, to make sure that everyone has an opportunity to benefit. And ultimately, reducing readmissions is really a focus, and essentially reducing readmissions is a focus because that's what governments are collecting at the moment around activity and efficiency. And really where we need to push things is around a greater focus on other things like improving care and improving the patient experience and outcomes. And that's what we hope to be learning through this project. It really is a phased approach to change that we're implementing. So Melanie just described the toolkit, which was really understanding the problem, defining what needs to change and how it should change. Where we're at the moment with the Prometheus project is this idea of the hospital readiness. Introducing this level of change is quite innovative, and we need to understand what that means, how ready we are, and what may work best within these settings. Looking at the interpretation of the data, does it work? What difference does it make? Who does it make a difference for, I think is really fundamental. And ultimately, does it improve care? So is it achieving what we all believe it should achieve? And then really establishing that clinical change. And we know that there's this concept of project fatigue that really is quite prominent within our hospitals and our health service. This constant sense of trying to change things but not really sustaining them. So that ultimate goal is to really sustain what is achieved through this work. This really illustrates the partnership approach to the project. You can't do this work on your own. I shouldn't say can't. It probably makes a lot of sense to do it in partnership with others. And this really outlines how we've structured the project to harness that expertise and that partnership approach. So the Heart Foundation is leading the project. We have an expert advisory group that we've set up, which is really our Brains Trust. It's not a steering group of the project, but more a Brains Trust around the concept of what we're trying to achieve and how we can best achieve that. We're working with 3 hospitals, one rural hospital, Bendigo Health, Austin Health and Western Health, and they have their own change process in place at those hospitals. And then we have our expert advisors on the side there with ICHOM and the Telstra Health, and also Chris Reed and the Monash Group, who are really interested in the concept of how we collect proms and also some of the evaluation we'll be undertaking. We've learned early on that it's really important that we consider patient flow and how it relates to data flow. There is nothing more disjointed than collecting data for data's sake that doesn't fit into your clinical care. So we're taking some time to really understand what is the patient flow of heart failure patients within the hospitals that we're working with, and how might the data fall out as a product of that clinical care and then go back into clinical care to inform it. And this is really fundamental because at the moment, again, in hospitals, there is this disconnect sometimes about data is collected for clinical purposes versus admin purposes and how those things come together or don't ever come together. We are developing an IT platform because that makes sense when you're collecting lots of data and you want to be able to analyse and compare data. And this is kind of the considerations that we're looking at in developing that platform. You know, some of the usual suspects there around how do you make this work within a very busy setting. But again, just reinforcing that we are taking time to understand the hospital context and patient flow before we start the build. And particularly on a lower budget, you don't want to be getting to a certain point and then having to start again when you've started the IT component. I also wanted to highlight here how important it is to understand that where you collect data about patients can vary because patients don't live in hospitals, they live in the community and receive services in many different places. So having a system that can have data and clinicians inputting at different points in the patient journey is also another key element of success. And we've heard this in Diane and Jacob's talk around the what's in it for me. Now that sounds incredibly selfish, but it's actually really important for engagement. We really want to understand here about patients. Why would patients participate in this? What's in it for the patient? What's in it for the clinician? What's in it for the funder? And what's in it for research? And traditionally, and I'm making a sort of a broad statement here, but traditionally the data we collect in our hospitals has really been focused around funding and research. And we really want to shift with the Prometheus Project this kind of concept of shifting it towards the patient and the clinician and how that informs clinical practice and is used for clinical practice. Because we're all really at the same, ultimately want to see improvement. All of this is really pushing this concept of how we improve. So when we were thinking again around the IT build, one of the things that we were really keen to ensure that it does is that if the patient has filled in these questionnaires in the waiting room, that becomes real time. So when they go into the clinician's office, that the clinician starts the conversation by saying to the patient, I see over the last 3 months or the last month that your condition has improved, that your condition has deteriorated, or there's certain things that I would like to talk to you about. So that should really drive the conversation and the clinical care that is experienced by the patient. If the patient never hears about why that questionnaire was filled in, they're less likely to want to continue to fill that in. And similarly with the clinician, if they don't feel that questionnaire is relevant to anything they're doing with that patient, then why would they do it? And I think that, again, the key thing around the conversation is instead of the clinician saying to the patient, your ejection fraction for heart failure improved by 10% since your last echocardiography as a success factor, it'd be great to say to the patient, I see that you're now able to walk to the shops, whereas you couldn't before, and I know that was important to you. And data has different purposes and we collect it for different reasons, and this slide makes the point that it all has a place, but there is a collective power of all of this when it comes together. And patient experience versus patient-reported outcomes, I think, is a really important distinction. Patients can tell you about their experience of healthcare, i.e., was the room comfortable? Was the chair comfortable? Did I feel heard? Did I wait too long or did I wait just long enough? What PROMS tries to do and what this project will try to do for heart failure patients is gives them a mechanism to actually talk about the outcomes and their experience of the outcomes that this care should be delivering. So instead of asking them about how have you found our clinic, it would be how have we achieved what's important to you and the outcomes that you wanted to see through your care. And by looking at this data, we know that the care would be safe, efficient, effective, quality, and of value to the patient that comes through the door. So important mechanisms, everything has its place, and collectively you can really look at the whole picture. What we want to learn from the Prometheus project, and we were very careful about scope and advice when you're starting off on these projects, it's important to not try and do it all at the same time, but recognising that it is a journey and there are elements and building blocks to that journey. We're really interested in this readiness aspect of hospitals to be able to capture this PROMS. What are the barriers and enablers for the heart failure methodology for PROMS capture, pathways to successful implementation, and also the resources that are required. And how acceptable really is this as a concept to the system, the health professional and the patient? It needs to work for everyone, otherwise there won't be ongoing investment in this. So picking up on the introduction earlier, so our early insights, and we started the project, sort of kicked off in January, February, and we've got a project manager on board now, Marina, who we've been anxiously waiting for because it's important to have a driver for all this work. But what we've learnt is many of the things that probably are familiar to you, importance of engaging clinical champions at all levels. So we required senior sign-off in the cardiology department and progressively down. Mobilising a change team, getting the right people in the right room at the same time. One of the fascinating things is when we go into hospitals, there are people in that room who may have been working in that hospital for the past 10 years that have never met each other, which is astounding, but it's true. So just bringing people together to have the conversation, again, is really powerful. There's a real willingness to engage with this. Clinicians understand the value of understanding what their patient wants and what matters to them. And we talk a lot about patient-centred care, but if the patient voice is not heard equally along the other measures that you're collecting, it's very difficult to deliver patient-centred care. The patient voice has to have an equal, if not greater weighting to anything else that you're doing within your health service. You need the capacity to drive change. Clinicians are very interested and very willing, but they're very busy. So that's why our model includes a clinical change facilitator that will be based at the hospitals to bring these teams together and do some of that legwork. The beginning phase is always, people are worried about the challenges. How will this work? IT is very complex in hospitals. How are my clinicians going to respond to it? Identifying these challenges early and working through them is really important, and that's where our initial meetings have been in working with the clinicians. And that's the obligatory cute animal picture. And it took me ages to find one that combined a cute animal and teeth, but I think I managed to do that. Thank you very much.
Don't go away, Harry. That was great. And to, where are you, Melanie as well? We have a gift. Thank you for giving us your take on the journey to value from the heart sphere.
Yes, thank you very
And
much.
extra points as well for references to ancient Greek history. It's one of my specialist subjects, one of my favourite subjects. Well done. Thank you. And next we welcome Malcolm Passmore. Malcolm is the chair of the Ramsay Health National Committee for the rollout of patient-reported outcomes using the ICHOM standard data set for PROMs. With 30 years of experience in healthcare management, Malcolm has worked in both the public and private healthcare systems. Please welcome Malcolm Passmore.
Good morning. Thank you very much for inviting me. It's very exciting for Ramsay Healthcare to be here and to talk about our journey into patient-related outcome measures and how important they've been for us. I'd like to recognise Jacob for the work that he's done with us with Caleb Stoll from ICHOM. Without them, our journey would have been more difficult. So who am I? Basically, I look after the 17 hospitals and 2-day surgeries across regional and rural New South Wales. I come from a clinical background, therefore I was chosen to be involved with patient-reported outcomes. The hospitals are a mix of medical, surgical, obstetric, psychiatric and rehab. But as mentioned, I chair the Ramsay Healthcare National Value-Based Healthcare ICHOM Steering Committee, which is a real mouthful. I also represent Ramsay Healthcare on the board of the Australian Private Hospital Association. Just to be sort of a bit proud, some of the hospitals that I am responsible for, the big one on the right with a lovely tree in the corner, is our newest hospital, that's Wollongong Private, which was only opened January of last year. Then there's Albury, Coffs Harbour, Lake Macquarie in Newcastle and Port Macquarie. So they're all very nice facilities. So what about Ramsay Healthcare? We've had over 50 years' experience in operating hospitals. The organisation was first came into being in 1964 with a gentleman called Mr. Paul Ramsay. Unfortunately, we lost Paul 2 years ago, but his legacy and his culture and his love for patients and his commitment to medical and nursing has lived on through that time. We operate across 6 countries, we admit over 3 million patients, and we're now ranked in the top 5 private hospital operators in the world. And that's an Australian company, still Australian owned. We're 32% owned by a not-for-profit organisation, the Paul Ramsay Foundation. So we do face a challenge for the tax department. As a for-profit company, we're 32% owned by a charity, but they're still not giving us any tax relief. We have 223 hospitals, 25,000 hospital beds, 38 emergency departments. We now operate 200 pharmacies. We realised about 5 years ago that we operated all these private hospitals and we had hundreds of contracts with pharmacies. We now operate our own. We do 1.4 million operations and we deliver 63,000 babies a year. We actually create a small town annually. And I was very excited to hear, and I actually asked some questions about one of your strategic initiatives being in regards to pregnancy and good oral health. And I will take information back to my facilities in New South Wales to utilise your program that I believe you have for educating mothers around good oral health. And we employ 60,000 people. across the world. So where are we? We have 36 hospitals in the United Kingdom, 123 in France, 1 in Italy. Now we did claim that, but it is a little tiny day surgery on the border of France and Italy. 3 in Malaysia, 3 in Indonesia, and of course our backbone is Australia. So enough about us. So what is driving us towards value-based healthcare? As you've heard from the other speakers, and I'm lucky enough to go fourth, so it'll be a little bit of repetition, but we do have an ageing and growing population. As you can see, life expectancy will grow to 73.7 years in 2019, increasing by almost 2 years from a decade earlier. But interestingly enough, the average age of a woman is now 82 plus that they will live. Men is still 79. And over 65 will represent nearly 11% of the population by 2009, a $640 million increase in the last 5 years. And of course we have the proliferation of chronic disease. Obesity, cardiovascular disease, hypertension and dementia are persistent and widespread health problems. Chronic disease will challenge both the public and private healthcare systems, and they are already. Diabetics are increasing and is expected to increase to 592 million by 2035. The other area that's driving massive increase in cost is innovations in treatment and technology. So genomics and the emergence of precision medicine, but also the medical innovations that we're now facing. You all would have heard of the Vinci Robot, which was developed by a company in the States, which is marketed out here by a company called Device. It's used for laparoscopic surgery, mostly for laparoscopic prostatectomies that we heard about in Jacob's presentation. The purchase price is about $3.8 million, and they're about $1 million a year to maintain and keep operating. One of the orthopaedic companies developed a robot to put knee replacements in. They cost about $1.3 million. All these products come with massive costs and massive disposables. The question we have to ask is the outcome better with the use of this machinery? So that's what we wanted to do. We wanted to look at it because there is a worldwide movement to progress quality in healthcare. And it's being driven by 3 key players. The payers. So as we saw earlier, the government and the health funds. Our organisation, Ramsay Healthcare in Australia, is 95% funded by private health insurance. In France, we are 100% funded by the French government. In England, we're a partner with the NHS, where we have 66% of our patients coming through the NHS. So payers are seeking to link payment to performance. In Australia, we still have the ICHOM number system for healthcare in medicine, where a doctor can raise a fee by preventing an item number. As you'll know, earlier this year, you may have read, or middle of last year, Calvary Private Group had quite a public stoush with Medibank Private because the payer or the funder decided to start telling the clinicians what they believed were preventable events within hospitals. And they listed 165 preventable events. They also questioned patients who would be readmitted. And they said that if you were going to have these events occurring, there'd be financial penalties. So if a patient was readmitted within 28 days, there'd be financial penalties. This is a big issue, especially for us that have one of the highest numbers of private mental health. As you know, readmission following a mental health admission is quite common in the first 28 days, unfortunately. And the same goes for non-clinicians deciding what is a preventable event. So these we looked at a way that we could say, right, we want to set the agenda. We want to say what quality outcomes are all about. Most importantly, the consumer. The consumer is becoming far more aware. They're demanding high quality care. They also want transparency. You would have heard recently that Medibank has partnered with HealthShare so that patients and consumers can actually see the out-of-pockets they face when they visit a specialist before they visit the specialist. If you wait 3 months to visit a specialist, you get in their room and they say, yes, I can do your operation, but it will cost you $10,000 out of pocket. Are you going to say, oh, well, look, I might wait another 3 months and see another specialist? It makes it very difficult. And we also have market leaders like the Martini Clinic, which, of course, Jacob had spoken about, where that quality leadership, that clinician involvement, that comparison of data is driving things forward. And radical prostatectomy in this country affects just as many men as the rest of the world. And we aren't seeing better outcomes with the use of the robot. But if we can see better ways of doing the procedure, for those that don't know, the Movember, the group that sponsors everyone to grow a sort of very fuzzy mow every November. I haven't done it yet, but my sons think it's very cool to do it. But they basically are sponsoring a worldwide PROMS project into radical prostatectomy. And in Australia, it's being run by the Urological Society. There's only one state that's not involved, that's WA, but they are coming to the table. And Monash is collecting the data. So in a few years' time, we'll have a wonderful repository of how we're treating radical prostatectomy in this country using PROMS. So we've talked about this, how do people choose, how do consumers choose what they're going to do? I think, as Jacob mentioned, reputation, hospital clinical indicators. In both the public and private system in Australia, we use the ICHOM clinical indicators. The volume, the staffing ratios. But as Caleb mentioned, what are the true outcomes? You know, am I going to be able to attend a function without having to go and change my underwear during the function? Will I have to wear pads? You know, will my social life, will my erectile function change after this operation? And will my cancer recur? So our journey was that we looked at what we were doing. We looked at things like the structural methods, the things that always done in the past, KPIs, ACHS readmission rates, theatre rates, falls, infection, morbidity, mortality. And we decided that it was more important to measure outcomes. So we have commenced a PROMS project, which I'll lead to. We're also now heavily involved in registries. There's lots of research in the world now saying that clinicians and hospitals being actively involved in registries will see an incredible improvement in patient outcomes. The clinician and the hospital is more focused on getting the best outcome through the information they get from registries. We're involved in the cardiac surgery register, the cardiology registry, the breast augmentation registry, the bariatric surgery registry. There's about 8 that we're heavily involved in now. So we formed an alliance with ICHOM. We became a strategic partner, I think is the term. And this gave us access to the material, but I will just note that as a not-for-profit company, anybody can commence a project. But if you want the support and the help, you need to become a partner or a sponsor. So as I said, the new measures we wanted to look at beyond immediate treatment outcomes. We wanted to measures which encompass the patient-reported health status. We wanted to know what the quality of the life of our patients was about, survival and disease control. But what we really wanted to do was step outside the hospital. As a private hospital operator, our focus had always been, and I mean this in the nicest possible way, a bit like a sausage factory. Patients were admitted by a doctor, we performed an operation or treated for their medical illness, and then we discharged them home with a discharge summary. But our contact with that patient would only reoccur if they were readmitted to our facility. And we believe it's important as a private operator that we take responsibility for the ongoing care and management of our patients into the future. So we chose to commence 6 patient-reported outcome measures: lower back pain, hip and knee osteoarthritis, cataract surgery in the UK, coronary artery disease, depression and anxiety, and breast cancer. Getting started. We're a very large company. So to get started, we needed to get approval, and we got approval from senior leadership and board. It needs leadership involvement. I refer to Jacob's 6 points at the end of his presentation. You have to have buy-in, you have to have the finances to do it. We also got support from our National Medical Advisory Forum. Of our 72 hospitals across Australia, we have a governance structure where there's a medical advisory committee. You may know of it as a medical council in some places. All of those have a chairperson. Those chair people come together once a year and meet with all of our senior executives, and we invite renowned speakers to address those medical advisory chair people. In 2015, we got Caleb and Jacob out to talk to all of our MAC chairs to ask them what they thought about this whole journey of value-based healthcare. It was a resounding success, I was pleased to say. And we had actually had MAC chairs coming up to Jacob and Caleb saying, when can we start, at that forum. So we formed an alliance in September of 2015. You have to form a national steering committee. Now, as again, we're a large organisation. You don't need to go to a huge level of bureaucracy, but you do need to have a national steering committee to drive the process forward. You do need to develop a budget. Have a budget so you know what it's going to cost you. At site level, have appointment of a lead clinician, one of your doctors who is really keen, because he or she will then bring their peers and colleagues along with them. And I'll give an example of, we had our first, Caleb visited Pindara Private Hospital and gave a presentation to the clinicians that were very interested in it. There was 3 of them in the room with the quality team from the hospital. And at the end of his presentation, they actually huddled in a corner and had their first steering committee meeting that day, then and there. Pindara has gone ahead in leaps and bounds because it has been driven by clinicians that are very interested. You need to meet with all your clinicians so they understand the importance of PROMs and value-based healthcare. You also need to understand what other research initiatives the craft group's involved in, and I'll give you an example of that. Orthopaedics has been harder for us to implement because orthopaedic surgeons and the orthopaedic colleges and the Australian Orthopaedic Association have done a lot of benchmarking. As you know, they have one of the world-renowned registries, and that is the Prosthetics Registry. So every joint that's put into anybody in Australia, there's a registry kept. And each orthopaedic surgeon also does a lot of their own research. Some of them even do PROMs and have done for many years. But one of the things they don't do is they don't share the information. They keep it with them themselves, their own rooms and their own practices. So when we approached a group to try and roll out PROMs, they said, oh yeah, all right, we'll do it because you want to use it as a marketing thing, don't you? And we said, well, no, we don't. But we already do all this. So be careful that you don't try and make people reinvent the wheel. Importantly, the Australian Orthopaedic Association is now talking to the Prosthetics Registry to actually commence PROMs across the country in a similar way that Movember is doing it with the Urological Society. So we may get our osteoarthritis one up and running. The steering committee at the hospital level has to involve the people who run the organisation, your quality improvement team, the clinicians. You need a secretariat. You will need to appoint a research assistant. We have a research assistant about 2 days a week, sometimes 3 days a week, because they need to keep the process rolling. And you'll also need to involve as many of the specialty craft group as possible. So what did we do? We selected the lower back pain. One of the things that the Atlas of Healthcare that we heard about earlier did point out was that lower back pain surgery can sometimes be questionable in regards to outcome. So we chose lower back pain because we do a lot of lower back pain surgery in the private system. North Shore Private Hospital, involving neurosurgeons, spinal orthopaedic surgeons, pain management specialists and anaesthetists, and also rheumatologists, is a very broad scope. It has commenced, and it has commenced collecting participants or patients or customers. We also have Pindara Private Hospital on the Gold Coast, which has 4 neurosurgeons. They've been collecting since May of last year, and they now have over 100 patients in their database, and they've commenced their second 6 months of data collection. We're doing the depression and anxiety standard data set at the Adelaide Clinic, just down the road. Adelaide Clinic, one state away. Albert Road Clinic, just down the road, and Hollywood Clinic in Perth. We're also doing the coronary artery disease data set at Greenslopes in Brisbane. And as I said, Ramsay UK has commenced 2 trials in regards to cataract surgery. A couple of speakers have mentioned IT. One of the things that did concern us was how we were going to manage the information technology of this implementation. We decided not to hide 2 of our IT people in a back room, give them a set of Excel or a set of databases and tell them to invent something. So we did speak to ICHOM and we said, what should we do? And we partnered with a company called Pulse InfoFrame, and I must say they've been fantastic to work with, even though they're based in Canada. So they do get me up very early in the morning to have phone conferences. But they have been absolutely fantastic. They're a registry-based company. Their whole structure is around developing registries. But they work with ICHOM for the standard data set. It's fantastic because it's web-based. So a lot of people, and I now talk generally, in the old days we said, oh, only young people would use computers. That's a complete fallacy now. All people use computers. I have a small hospital in Armidale and we introduced a Wi-Fi system across our company. The CEO of the hospital in Armidale said, I don't want to spend all that money on Wi-Fi because no one will ever use it. And we said, no, it's a company initiative, please install it and stop whinging. So she did. She actually sent me a picture a week later of her first customer who'd logged on to their Wi-Fi system. It was an 89-year-old gentleman with his Apple computer. So we wanted a web base, so you could use it on your phone, your iPad, your PC. We wanted someone with a well-recognised history. We didn't want the software to fall over. Nothing's worse than a piece of IT that doesn't work. Now, you'll notice that I've been actually talking for, I think, about 20 minutes, and the PowerPoint hasn't stalled yet, so things are improving. We also made sure that Pulse visited all the registry sites to make sure that they understood the technology. It's competitively priced. I can't divulge the price because, of course, it's commercial in confidence, but it is below $100,000 a year for us to run 5 sites across the country with full support and full web-based backup. There are huge costs if you start thinking about doing this manually. You will spend lots of money on paper and people. So always run a cost analysis of labour versus IT. If the IT works well, it will always give you a better outcome financially than labour. There's also a reduced bias and response. If a patient is filling out on their iPad the questions, especially in the prostatectomy area, if a man in his mid-50s who's had cancer of the prostate gland and has a radical prostatectomy gets a phone call from a 25-year-old female asking him whether his erection function is still good, it's quite difficult for that gentleman to say, yeah, it's going really well, when it may not be working at all. Where if they're actually just writing it into an iPad or an iPhone or their own computer, you will get a more accurate answer. And another thing that Jacob said in regards to his was, you have to have reporting immediately. That's what Pulse does. So our doctors at Pindara can look at their data now for their patients now. They can see the improvement, they can see the outcomes. So one of the things with Monash, they will collect up to 18 months data before it's released. That's a long time and it's a lot of information that will be held back. So that's something I know Monash is working on a lot. In the background, as you get these things set up, you will need ethics approval. Don't be conned by the people that say it's a quality project, therefore you don't need ethics approval. In Australia, with the privacy legislation, you are safest to get ethics approval. And also, if you want to publish in Australia or overseas, recognised journals will always want to see ethics approval. As I said, report a dedicated research assistant because they will develop your ethics application and they'll also work with Pulse. We had to do quite a lot of work with Pulse because it was a Canadian tool, so we had to Australianise it, and that wasn't as easy as you'd think, but even weights and measures are different. Some anacronyms are quite different. Continue to work very closely with your clinicians and your practice managers. Your practice managers will drive this process because they will help you choose your clients that you're going to enrol in the process. Develop a strategy from the very beginning to educate all your staff. Ensure all sites, steering committees, report back to the National Steering Committee. That way you have a repository of knowledge of what you're doing across the country. Still to come is 12 months worth of data for us to commence benchmarking. We have now the second 6 months at Pindara, but once we start, we have a 12 months. Jacob and Caleb tell us we will have enough data to actually start internationally benchmarking as well as nationally benchmarking, which will become incredibly important for us. And importantly for us as a private company, we wanted to develop a marketing strategy around what we do with ICHOM and patient-reported outcomes. Some tips. Start talking with your ethics committee early. Don't just run up to your ethics committee and dump this on the table. They won't understand it. They won't understand that ICHOM's a not-for-profit organisation and that the standard data sets are given away freely. Always test your tools that you're using. Get your clinicians to test their assessment because issues surrounding multiple levels. We had to make some changes to the standard data set with the approval of ICHOM in regards to some of the spinal surgery that they do in Australia versus the way the data set was written. And ICHOM was quite happy for us to include extra thoracic joints that we operate on in Australia. Determine how you want to publish your outcome data. Surgical versus non-surgical, age, diagnosis, procedure type, comparing implants or techniques, the impact of additional procedures on study inclusion. Be careful when companies come to you and say that they will sponsor your PROMS project and that if you're a heavy user of one of their disposable items or their prosthetic items, because you want to maintain the efficacy that goes with it being run by the clinicians for the clinicians for the best outcomes of the patient. I'd now like to show you a video. This was to help us encourage people to fill out their prompts.
Hi, I'm Trish Hogan. I'm the CEO of Pindara Private Hospital. Pindara is taking part in an international medical research project to find out what matters most to patients. The research is part of an alliance between Ramsay Healthcare and the International Consortium of Health Outcomes Measurement, ICHOM, and we need you to be involved.
Why has Pindara been selected? Pindara is one of a few private hospitals in Australia with a dedicated neurosciences unit. This cutting-edge unit is serviced by an experienced team of neurosurgeons who, together with their patients, will play an important role in the ICHOM research project.
Pindara's focus in the study is on lower back pain and spinal conditions and the patient's experience following spinal surgery.
The results of the ICHOM research will contribute to an international data set of low back pain, and it will be published internationally.
Long term, the research will help the medical profession identify and develop the most appropriate treatment and surgeries for specific spinal conditions.
That not only gives the best surgical outcome, but also the outcome that you are most satisfied with.
As in any research project, we need to gather enough information to make a difference. All the patients having spinal surgery here in Pindara, we need your support.
It's easy to get involved. Just sign the project consent form and fill out the survey either online before your surgery or in person at your appointment today. If you forget to fill it out before surgery, we will call you to go through the survey over the phone. Your progress will be monitored over a 2-year period, so there will be a total of 4 surveys to fill out. The first will be completed before you come in for surgery. The second will be completed 6 months after your surgery. We'll send you a reminder. Surveys 3 and 4 will be completed in the following years. We want you to really think about your experience and record as much detail as possible. So we expect each survey will take around 15 minutes to complete.
This global research is very important. Your involvement will make a difference. So please join us and help us improve the quality of life for those suffering with lower back pain around the world. Thank you.
The patients see that video when they open their iPad up, and that's their introduction to the ICHOM project. There was a suggestion that we should buy $50 Woolworths vouchers to encourage them to fill it out after 6 months. I did work out the cost over 5 years, and we made a second video that they see to encourage them to fill it out at 6 months. Just quickly moving on then, I've talked about the iPads. They're in the doctor's rooms, they're in the wards, and the patients have full access to them. We wrap them in very large pieces of red foam. So if you see people sitting on a tram with an iPad with a big bit of red foam wrapped around it, you'll know that it was once used for proms at a Ramsay healthcare facility. And of course we've done a lot of trialling, and we work closely with Pulse the whole time. Just to see how we've gone in our first 6 months, these are figures from the Pindara project. As you can see, of the 100% eligible patients, we received 60% consent to do the ICHOM project, and this is the lower back pain. And of that, we had about 42% that have completed their PROMS information. The research assistant, as I said, is vital for ongoing management, to keep contact with the patients at pre-admission, to help with data capture and analysis, to maintain relationships with practice managers, surgeons and staff, and to ensure the ongoing promotion of the project with marketing. And of course, keep educating your staff. I'm only going to put these up just to show, these are very early graphs that have come out of Pulse for the 6 months. But as you can see, from the range of surgeons that we have, we are showing an improvement in this. This index is one part of the standard data set for lower back pain. I'm not a clinician, so I won't talk, but it does show that we are starting to get information out of here that is improving the outcomes of our patients' lives, and this is the stuff we want to demonstrate. So the challenges for us were cost and resources. This type of private collection was new to the private sector, and we have a budget of around $500,000 a year to run this project. But that includes international travel for if there are conferences. So in the first year, 4 members of Ramsay Healthcare travelled to the UK, where they stayed for a week to attend the ICHOM conference in London to give us some knowledge of the process and also to have a nice time in London. You need to convince your doctors that we are not using a stick. This is about helping them with patient outcomes. Understand the Privacy Act. What's important? Make sure it's clinician-led. We want to have global benchmarking. As a company that runs 200 plus hospitals across the world, we want to compare our outcomes in Australia with our outcomes in France. We want to compare the work we do with the NHS in England with the work we do in Australia. We operate 4 public hospitals in Australia, so comparing data across the public system is important to us. And we want to refocus our hospitals outside of their own walls. We want them to connect with their patients. We want them to have an ongoing relationship with how the outcomes that we deliver in hospitals keep delivering great outcomes for them once they're in the community. So in summary, for Ramsay Healthcare, we have a thing called the Ramsay Way, which you'll see on our website, that was written in 1985. It's all about how it's about people caring for people. We see quality and we see what we're doing as driving that initiative. We've had over 50 years of uninterrupted focus on patient quality and safety. We deliver value to our customers, and we want that value to come through to our doctors, to our patients. We don't use the term value-based healthcare very much. We use the term patient-reported outcome measures and great improvement in care. We want our doctors as a group to identify outliers and then educate that outlier to improve their procedure. Yes, it is about value. It is about getting the most efficient and effective service. And I know that in both Victoria and New South Wales, the state governments are looking very closely at how they can get their clinicians working to the best value for what they do. We want to be a leader in quality and safety. And to do that, we have to take a proactive role. We don't want the health funds telling us what a good clinical outcome is. We want to tell them what a good clinical outcome is. So why? I think I've said. So thank you very much, and it's been great talking to you today.
We do have a few minutes for questions from the floor if you'd like to ask Malcolm or one of our earlier presenters this morning. We've got about 10 or 15 minutes, so who would like to kick us off? We've got a roving mic that'll work its way around the room. Just raise your hand and, yep, down the front. Where's Julie? Oh, there's the mic now. Okay.
Hello, my name's Kathy Bell. I'm on the DHSV board. Thank you for that presentation. It's been a fantastic morning, I think. All the presentations have been really valuable. I just wanted to ask, in the context of the work Ramsay Healthcare is doing, you're talking a lot about getting clinicians on board, but the focus seemed to be very much on doctors, and I wondered how you're addressing the whole healthcare team and involving the whole healthcare team in your work.
Yeah, I think I did emphasise how important it is to lead from a clinician lead, but for example in our mental health facilities it's being led by more the nursing staff in the ward that are having the time with the patient. As Jacob said, a lot of the data sets are purely patient driven. The doctor input is quite small in a lot of cases, and in the mental health data set it's just like that, and it's the nursing staff, it's the post-discharge follow-up nursing staff that are heavily involved. We're also involving, in regards to the cardiac data set, it involves the cardiac technicians in the cath lab, it involves the radiographer in the cath lab, and that's what I kept saying about staff education. We need a clinician lead that's a doctor, but they've got an absolute team of people behind them that are doing a lot of the legwork.
And just one over here. Yep, thank you.
Hi, Shane Maguire, formerly of DHSV. There's been a lot of chat today in the discussions around outputs. I'm wondering what people think of a concept of output funding as a basis rather than outcome funding rather than output funding. So state public dentistry is largely output funded. 20 years ago I wrote a paper that proposed an outcome funding basis for public dentistry in Victoria, and the state government wasn't very interested. So I'm just interested in what speakers think of outcome-based funding.
Jacob?
I can take that. Yes, certainly we're very much in favor of value-based payment models, what those models look like. We do have some early evidence coming from countries like Sweden specifically that have a very long history and a very well-established registry system. And that's really critical to understanding, to first of all developing risk adjustment models to understand, compares the data appropriately, but also being able to understand what is an appropriate complication rate, what is an appropriate revision rate, so that you're not penalizing providers needlessly. So there's a value-based reimbursement institute now in Sweden, for example, that has bundled payments that are risk adjusted for the patient complexity, but also include either payment reductions or bonuses based on PROM scores after 1 year. And that type of bundled payment is typically what we would advocate for as an outcome-based or value-based payment model. It's a little bit more complicated when you look at primary care or population-based health type of payments, but we do have early examples of that model working very well. And actually high-performing service providers doing very well under that model in terms of their profitability.
Would anyone else like to respond to that question? Yep. Harry?
That primary care concept is one that the NHS really looked into, around the concept of enrolled populations of people within their general practice, and particularly around areas like diabetes or some of the more known risk factors, so for hypertension. And what they did was actually paid on people achieving their outcomes for particular targets. And it has been shown to definitely drive practice towards those models. But like everything, it has some drawbacks as well, because then what you set up is a system that is based on every single improvement needing a payment to achieve that outcome. And it kind of loses to some degree that focus about continuous improvement, and that people and healthcare needs to be continuously moving towards better evidence, better guidelines and better practice. So I think it's just important to be aware of it, but certainly there is a lot of evidence to show that when you pay for outcomes, you get more outcomes. When you pay for more activity, you get more activity. So one comment that the latest chronic care review out of Canberra, that was one of the recommendations that they're rolling out, a bundled patient care model for primary care. All I say, and this is not a Ramsay comment, this is a Malcolm comment, all I say is that I think when my grandchildren grow up, there won't be a fee for model service.
Any other questions? Yeah, one down the front.
Hi there. I'm Tu Trang. I'm a member of the CAC committee. I'm just concerned, one of the things about outcomes-based funding is that you can see the effects of cherry picking and creaming, which has occurred in other parts of public service delivery. So how do you counter that in the health system where people might avoid hard-to-treat patients?
Jacob?
Yeah, I guess I would have two responses to that. First, again, getting back to the risk adjustment. We know that risk adjustment is not perfect, especially for outlier institutions that have very extreme case mixes, but it's important to have good risk adjustment methodology to make sure that that the hospitals that are taking those complex patients aren't being penalized for that. The other thing is that what we see happening in the Netherlands and Sweden, where they're further along this path, is they're creating a roadmap to transparency and accountability that starts with improvement in learning. And if you're using the data internally to improve and learn, there should be less incentive to try to game the system, because you'd only be hurting yourself. So in the Netherlands, for example, there's a nonprofit institute running 23 national registries now, and they have the first 3 years are just data collection, where there's a pay for reporting. So there's an incentive to collect and report the data only, but there's no transparency and there's no payment tied to the outcomes. And then the next 2 years, they're given the opportunity to improve or understand their relative performance before anything becomes transparent and publicly available, or any league tables are published, for example, or any payment is tied to them. So I think that's the key, is actually creating a roadmap and giving people the ability to improve before there's any of that accountability piece tied in.
I sort of had the feeling I probably need to say something. I'm Deb Cole from Dental Health Service Victoria. With respect to the sort of roadmaps, we're actually on this journey of value, and part of what we wanted to do today was to start the conversation and let you hear that we're actually starting to develop these health outcome data sets for oral health. There's a lot of conversation in health right across Australia, both public and private, about moving from a fee-for-service model to a more outcomes-based model. What will it look like? We don't know yet. But part of our opportunity is for all of us to work together to actually work on what it might look like in the future. But it's not going to happen tomorrow, but it probably will be different. And I think, as Malcolm said, you know, his kids and my kids will certainly be living in a world where the funding model we have now won't be the future one. But we have an opportunity, I think, to actually help form what it might look like in the future, and I think that's a really exciting opportunity.
Thanks, Deb. Any other questions? Okay, we might take an early lunch, I think. Thanks to Malcolm for his presentation, but before we break for lunch, I need to explain what's happening after lunch. We're going to break into two groups. Stream 1, creating partnerships. Please come back into this room with me. Stream 2, working in new ways. Please go to room 203 with Louise Palmer. It's just across the foyer on this level, so you can't get lost. When you hear the music again at 1:45, go to one of the rooms to hear the innovators. We ask that you remain in the room for the full session as a courtesy to our presenters. Both sessions will be videoed, so you'll be able to catch up on the one that you don't go to today. And if you indicated when registering that you had a dietary requirement, your food will be labelled and on the table out in the foyer. Okay, also don't forget to visit the trade tables during lunch, and I'll see some of you back in this room for Stream 1. Enjoy your lunch. Thank you.